We are live. I think we are live. Are we, Sanjeev? Sanjeev?
Yeah, it is live now.
Okay.
Sir, you are
Sir,
live.
we are
You
live.
can start.
Yeah. So, welcome. Welcome to this fantastic, I would say, episode of the unlocking of the lockdown. And it's very interesting because we were thinking of a title, and Dr. Agarwal came up with something fantastic, which was Khulja Sim Sim. So it became Khulja Sim Sim. And there's a very beautiful thing about us doctors. From the time we joined medical college till this time, we always say all is well, all is well, all is well. And keeping this in mind, एक बड़ा खूबसूरत शेर मेरे दिमाग में आया, सब डॉक्टर्स के लिए परफेक्ट है कि मेरी हिम्मत को परखने की गुस्ताखी ना करना, मेरी हिम्मत को परखने की गुस्ताखी ना करना, पहले भी कई तूफानों का रुख मोड़ चुका हूं. And this is the beauty about our medical profession, that at this time when everybody is thinking कि अपनी जान बचानी है, we are thinking how do we unlock safely for people. That's the only thing we're thinking about. And that is the reason such beautiful people like you have taken the time out to join us, because we have some fantastic, I would say stars. Stars, why? Because, you know, they shine. We have some stars over here to tell all of us about the beautiful things about this crazy thing known as coronavirus and its unlocking. So I would begin with the first slide, please. This is being held under the aegis of, it is being held under the aegis of the Global ART Forum. It's Dr. Ashok Agrawal, of course, will let us know exactly what the Global ART Forum is. But the dictum is, let us all just do it together. Let us all just do it together. And that's the way it is. I would like to introduce our moderator for today, whom everybody knows. But still, हिंदी में बोलते हैं ना, ये किसी तारुफ के मोहताज नहीं. But फिर, Dr. Ashok Agrawal, who is the head of Andrology Center of Cleveland Clinic Foundation, Ohio, USA, and is the director of American Center of Reproductive Medicine. He has one of the largest numbers of accepted publications in the top journals of the world. And of course, he must have lost count of the books he's written. Dr. Ashok Agrawal, please, I cannot say the stage, but I definitely would say the screen is on to you, sir.
Thank you very much, Sunil. It is indeed a great pleasure and something that is a beautiful day for us to begin this program. Welcome to everyone who is online today to this amazing program of Khulja Sim Sim, unlocking the secret of how to get back into the practice for all the physicians, all over India, as well as in many parts of the world. So I believe that we have a wonderful program. If I can move my slide, let us see this. Okay. So I want to introduce the Global ART Forum. What is the Global ART Forum? The mission of this Global ART Forum is that it is a free, not-for-profit, non-political platform that shares the latest knowledge, which is really embedded in science and facts with reproductive professionals, which are empowering them in turn to take good care of their patient. And this is really the mission. Our vision is a collaborative live educational forum of medical experts for reproductive professionals that assist them on the path of continuous learning and clinical excellence. So with these thoughts, we had created this non-profit, non-political platform. And we are here to welcome all of you to this webinar. This is the third in our series of webinar that we have done as a result of this very unfortunate pandemic which has affected everyone all over the world, whether we are in the United States, whether we are in India, whether we are in Europe, everywhere. Right now, I'm in my home in Cleveland, Ohio, and it is early morning here. I was just telling Alpesh, he was asking, you must have eaten the parantha and all these things. I said, I'll have nobody, but I have to make those parantha myself in order to consume at this time in the morning, because that is not going to happen so early. So it is a great pleasure for me to start this program and welcome all of you. This is the real luminaries from all over India, uh, some of the topmost experts in the field of medicine, as well as from abroad. We have people that will be coming from the United Kingdom, Dr. Alpesh. But I think we have a great galaxy of very, very smart and very well-renowned experts to provide different dimensions of how we can get back into the practice safely. And the intent is really to provide a roadmap. Of course, you have the guidelines that the government is sharing, you have the guidelines that the societies are sharing, whether it is FOXY, whether it is ISAR, whether it is IFS, but how to really put them into practice. There is a lot of thoughts that will go into putting them and customizing them for your own practices, for your own nursing home, for your own clinic, for your own laboratories. And that takes a great deal of thinking and thoughts. And so it is really a process which we are beginning here, is to allow you to start thinking and then taking those thoughts, those ideas that will be shared, and put them into your own practices as you begin to grapple with this situation and start to serve your patients in the coming days. So with that thought, I will introduce our opening batsman, and he is Dr. Dr. Sunil Jindal. Sunil Jindal comes from an illustrious family, and he is, and his wife, beautiful wife, Dr. Anju, she is a OBGYN specialist. They run a very well-renowned hospital called Jindal Hospital, which is a legacy of their parents who were physicians, and they started this hospital, and it is being actually expanded in their services. So he, if you look at his CV, I think I don't know where to start, because there are so many firsts and so many things that he has done. But I think on a personal level, I mean, he is definitely one of the top laparoscopic surgeon and andrologist, and has a wonderful practice along with an OBGYN practice. But on a personal basis, I think he's a very um, wonderful friend and a colleague. And I think on a lighter note, I think he provides these share and shairi, which are really top class. I mean, I think I really like somebody to lighten the mood of this very difficult times that we are all going. So I want to really thank Sunil for bringing those lighter moments. I'm sure he has thousands of worries of himself, of his own practices, but how he can manage that stress and be able to shine through it and try to lighten the mood is one of the special qualities of Sunil, which we have all to learn in this very difficult time. So with that, I give the stage to Sunil to begin his presentation. We have 8 speakers, so we are requesting each speaker to speak for about 6 to 7 minutes, and allow the second and the third speaker to continue, with the hope that we will be able to finish in about 1 hour, and then allow 1 hour of question and answer from the delegates who are attending this online seminar. So Sunil, please proceed. Welcome.
Next slide, please. Next slide, please. Actually, Dr. Agarwal has given me a test match and he's given me the timing of a T20. So, you know, the truth is, why are we doing all this? We're doing it for 3 reasons: to protect ourselves, to protect our patients, and to protect our families, their families, the community and environment. Next slide. Next slide, please. It's a chain of transmission, and we need to break the chain of transmission for isolation to stop people from having this problem. And also we need to break this chain of transmission for one prime reason, that our hospital staff and we should not get infected. Next slide, please. Now, I have tried to make a small flow chart. This flow chart is very interesting because the moment a patient enters, the patient enters into an area at the gate, which should be a wash area. It should be an area where the person could wash the hands and come to the first stage where the people would be scanned to see whether the patient has a suspicion of COVID or not. If there is a COVID suspicion, then the patient in most of the places, as per government regulation, needs to be referred to a COVID institution. If you feel it is non-COVID, then you go in for registration. Once the registration has taken place, the patient goes to the waiting area, which should not be too much, goes to the doctor's chamber or goes to the hospital, goes to the laboratory or the pharmacy, and finally the patient goes out. So I'm just trying to give you a very close overview of the way it can be done. And I'll give you a link, everything written down over there with all literature for you to study and understand it in detail. Next slide, please. Next slide, please. So I'm first of all going to talk to you about the washing area. So a washing area is to be having soap and water. The tap should be either an elbow run or a foot run. Tissue should be there to wipe. There should be posters for hand washing technique, and mask should be given to the patient if the patient does not have one. The next is in the triage area. If the patient can walk, please do not give this patient an attendant. The patient should come without attendant. There should be physical distancing. The form should be filled either on computer, but there should be no hand. It should not be given into the hand of the patient. Sanitize the hands, see the vitals. The vitals are only going to be seen after you have sanitized the patient or the patient has hand washed. And this is the time you would see the vitals. If you suspect that the patient has COVID, notify authorities, fill the registers, send the patient to the COVID area. Non-COVID is allowed into the registration area. Now in the registration area, please have an appointment system. Patient should come by appointment, 10 o'clock, 10:15, 10:30. That's the time he should come. There should be no crowding, no attendant, document details in a computer. These should automatically go to the doctor's chamber. If any fee needs to be taken, please take the fee by an electronic transfer. And if you're taking cash, have a small box with some formalin tablets in which that cash can be placed. Next slide, please. Another interesting thing is the waiting area. In the waiting area, the patient should, I'm sorry, can I go back to the previous slide, please? Dr. Agarwal. Yeah. So in the waiting area, the patient should not wait. There should be stools instead of armed chairs. They should be kept at least 4 feet distance. And the most important area is the distancing should maintain. Now it comes to the doctor's chamber. The doctor's chamber should ideally not have an air conditioning because air conditioning is not good. And if it is there, the temperature should be between 25 to 30 degrees. Most of the patients who do not need an examination, please do not examine them. There should be no touch. The doctor should have the PPE, which I'll tell you about. There should be a distance of about 4 feet. In case you're using a stethoscope, Sanitize the stethoscope every time you use it. Please sir the records on paper from a distance. Don't take the file into your hand. Make entry into the computer or the papers. And the most important thing is that your hand hygiene should be maintained. One thing which you should need to do is, once the patient leaves, there should be sanitization of the seat of that patient. Next is in the laboratory. In the laboratory, remember two things. You have to take universal precautions and you have to have proper biomedical waste protocols. This is the most important thing. Next slide. Next is pharmacy. In the pharmacy, in the pharmacy, there should be proper distancing. There should be a glass partition, limited staff. If your pharmacy needs 3 people, have 2 people. Avoid handing prescription, prefer electronic, place all medicines in a cover, and most important, disinfect the counter always with a sanitizer. You have to have some records kept. These are the triage form, which is form number 1, which I have in the link I'm going to give to you. You have that form for referral should be there if you're sending a patient to a COVID hospital. There has to be a register for that referral, which is known as the notification register. There has to be a disinfection register, a staff attendance register, and a staff training register. Along with that, there are some norms of disinfection. There has to be a control team. There has to be a chart. Every 2 to 4 hours, disinfection should take place. Use 1% sodium hypochlorite for cleaning, 5% Lysol for the ward and theater, and a 3-bucket system and sprayer for the floor cleaning. Staff management, training has to be done for everybody. Please have only the number required staff present. Keep 30% in reserve. Give your staff chemoprophylaxis and do not mix the staff of the which you have kept for the isolation ward and the rest of the staff. Next slide, please. Dr. Agarwal, next slide, please. Now you have to do a risk assessment. This you have to do on your own. You have to understand which is the procedure for which you would get in contact with blood, body fluids, respiratory droplets, or open skin. Next slide, please, sir. The one before this, yes. So we need to understand that in case we are just going to be in contact with the patient, we need good hand hygiene. In case we are going to get in contact with any body fluids, we are going to use gloves. In case we feel that a splash could take place on our clothes, we wear a gown. And most importantly, if we feel that the splash may take place on our face, then we need what is known as a eyewear and a medical mask. Next slide, please.
You have 1 minute to finish.
Right, sir. I would be through. Now, a person at the reception where we do not know what the patient is going to come by with needs a full cover cloth dress, N95 mask, cloth mask over that, and a face shield. Fever, if there is a ward which has fever, full cover cloth dress, N95 mask, cloth mask over that, face shield, gloves if BP and temperature are checked. If there is a normal OPD staff or a laboratory staff anywhere in the normal ward working, a 3-ply cloth mask, face shield, and gloves would do. Housekeeping would need a plastic apron, long gloves, leggings, cloth mask, and a face shield. We need to understand all these clothes need to be kept for 15 minutes at the time of washing in 1% or 0.5% sodium hypochlorite. Immediately wash with soap and water. Face shield can be washed by soap and water by keeping it for 10 minutes. N95 mask needs to be just hung for 72 hours. Please understand, all these things need to be done by us. There should be a register in which everything is entered. And that's where I'd like to end it. You could go on to my Instagram. This is it. I have put all the links of all these forms into my Instagram bio. You could just pick up all these from there, including this presentation. And this is a very trying time for all of us. We all need to understand all this. Dr. Agarwal, in 6 minutes, I tried to be as fast as I could. Thank you very much, Dr. Agarwal, for all this.
Thank you, Sunil. Thank you for a wonderful presentation with so many details, so many things that you have explained, even providing the pictures for people to visualize how these changes are going to take over. So I want to thank you, and we want to move on to the next speaker. And our next speaker is Dr. Alpesh Doshi. Alpesh is a world-renowned embryologist as well as a co-founder of IVF London. He is a great friend and someone who's really, I think, a role model for many of the people who are working in the field of IVF. He is a gentle, humble, and a person who's extremely intelligent and smart. So I'm really, as a group, privileged to have Alpesh join us from London to share something which is so valuable for thousands of IVF clinics, both for the clinicians as well as for our reproductive professionals and embryologists. So I will ask Dr. Alpesh to take the stage now.
Thank you so much, Ashok, for that very kind introduction. It's absolutely a privilege to be speaking in such a well-reputed forum, and thanks to the organizers and Intas. So I'm speaking mainly about reopening the lab or the IVF clinic post-COVID-19, and specifically the UK scenario. Can I have the next slide, please? So we all know that centers have to open at some point. And in the UK, we have our governing body called the HFEA, Human Fertilization and Embryology Authority. Opening is not very straightforward. We need to submit risk assessments and a COVID-19 reopening strategy to the HFEA before they give us approval. They typically take around 5 to 6 days. The portal for submission is only going to be open next week, and we will certainly know after submission of all those documents whether the clinic is ready to open its doors to patients. And of course, opening is going to be a very gradual process, and not just like opening a floodgate and letting all the patients through. There's quite a few parameters that we really need to look out for, more towards clinic staff who are also providing patient support, and most importantly, patient awareness about the current situation and how treatment is going to resume. So it's quite important that centers also seek opinions of professional guidelines. In the UK, we have the HFEA, we have Association of Reproductive and Clinical Scientists, the British Fertility Society, and of course the international societies like ESHRE and ASRM, who have their own side of things at the moment. Now, the next slide, please. We are also aware that the triage is going to happen. And of course, in the UK, what has been suggested by ESHRE is a 2-stage triage protocol at the beginning, i.e. 2 weeks before a patient is seen and at the beginning of stimulation. And anyone who's triage positive will potentially have to have antibody testing done. Anyone who is COVID positive will have to defer treatment unless they have risk of severe OHSS or cancer therapy. Social distancing is going to be very much the norm within the clinic. As Dr. Sunil said, contactless or digital payments are going to be the norm as well. Exit point and exit disinfection with alcohol gel when it comes to patients coming in and out of the clinic. Every appointment will have to be spaced out as well. Typically for scans, we will have to keep 30 minutes between patients. And for any egg collection procedures, it'll probably have to be 90 minutes or more between patients. And with very busy clinics, they may have to do shift works, i.e. morning shift and evening shift, if they're typically doing about 8, 9, or 10 egg collections a day. Next slide, please. So in terms of the laboratory, we know that the lab is one of the key functionality areas. Deep cleaning is going to be a must to open up. Typically, walls will have to be washed down, floor, benches, all the equipment will have to be revalidated as well, because you may have shut it down pre the lockdown. Equipment will have to be sterilized, all the high temperature sterilization systems. It's quite advisable to potentially even use a hydrogen peroxide bomb in the lab overnight so that everything has been decontaminated very well. And of course, there shouldn't be a concern about hydrogen peroxide in an empty lab because it breaks down to air and water. You should have effective disinfecting solutions or agents, and a good one to be able to use without any concern about toxicity to embryos is oosafe. And this has been shown to be effective against COVID. Please be mindful of your air handling units and the change of filters within your air handling units, because again, the virus is airborne, as we know, and can be trapped within filters as well. Quite imperative to be using UV lamps as well in your flow cabinets overnight. So I know we don't use it in the lab during the mornings, but at night you can put it on a timer so it goes on every night. And of course, effective sanitation protocols between patients and effective sanitation at opening and closing of the lab. Next slide, please. So personal protective equipment is quite important. Make sure you've got new batches of scrubs ready when you start up, rather than using the ones left over pre-lockdown. Disposable gloves, hats, FFP2 masks, gloves, and full gowns. And all of that has been explained by Dr. Jindal very well. Now, visors are also quite important anywhere where there is a risk of any splashes. Clogs, usually 2 pairs, inside and outside the lab. And a 6-step hand washing technique has to be quite mandatory, especially in this day and age, especially with the risk that we have. Chlorhexidine is a good soap to use, which will be effective against COVID. Next slide. Now, the egg collection, the lab procedures, of course, typically examples are egg collection. You want to make sure that there's disinfection of laminar flow hoods between patients. Make sure that the follicular fluids and the semen are diluted before discarding. You want to seal the containers very well before discarding so there's no leak or risk of leaks. You want to double bag all the waste that comes out of the lab every day. Consider daily disposal of sharps bins. Try and go paperless if you can, because again, the more paper you touch and everything, there is a risk that you're cross-transmitting. Consider semen production off-site. I know some clinics in America are doing roadside drop-offs of semen sample. Again, consider doing that if possible. If you have a time-lapse system, try and use that so you don't have to take the dishes in and out of incubators and subject it to various different areas of work. Avoid using and sharing pens, because again, you may be touching things, someone else may be touching things. If you've got more than one embryologist in the lab, that may be a risk. And of course, sanitation of all pipette holders in between patients. Try and dispose of any unused consumables by the end of the day. Next slide, please. And of course, embryo transfer, we have to be very careful. We want minimal staffing. In the UK, it's been advised partners should not be there during embryo transfer to minimize the number of people. Freeze all if patient experiences any symptoms of COVID post egg collection. Cryopreservation, of course, the lab should consider using a closed system for vitrification for any COVID positive patients, or potentially extended to symptomatic patients. Consider COVID testing for men who freeze semen. And I'd love to hear more from Ashok, maybe what his views are on that, considering the bioburden. Now, the good news is that the eggs and sperm, eggs and embryos do not have receptors for COVID. And the bad news is that the virus can be cryopreserved and can be present in the media that we freeze the embryos with. And hence, when we do an embryo transfer, potentially, the virus can be introduced into the woman and hence infecting the patient. So, as much as we know that it doesn't affect eggs and embryos, it may affect the patient because the virus can be carried over. It's important to risk assess, as Dr. Jindal said. It's important to bear in your risk assessment the staff to staff risk, the patient to staff risk, the sample to staff risk, and of course the sample to sample risk. All these have to be really laid properly down in a documentation, in a very thorough documentation system, to ensure that you've done a full risk assessment before you open up the lab. Did I overrun?
You are absolutely in time. I think, Alpesh, you have done a tremendous job. Congratulations. And I want to compliment you as well as Sunil to really provide a great deal of clarity in terms of how the clinics can begin their operation with this lockdown being lifted. And I think your perspective and the one which Sunil was not overlapping, they were complementary. So your description of how the clinics and the labs need to really take so many different measures is eye-opening. I believe, I mean, I'm learning the things as I'm hearing you. I know you made a comment about whether the sperm freezing can be done. We are actually conducting the sperm freezing, and this was going on during the entire period of last month and a half. There is no real evidence regarding the transmission of virus during the process. So certainly the patients who are coming are being screened by asking all the proper questions about their history and their travel, and these things are done over the phone, and only those patients who really report that they have no contact, they have not traveled, are the ones who receive the service. So we have been entertaining oncological patients for the last several weeks. So thank you once again, and we will come back to you, Alpesh, so you can mute your
Thank you.
microphone now. Thank you. Thank you. So now we go to our next speaker. Our next speaker is Professor Shanta Kumari. Uh, and I am sure that most of the people who are online know her, but I have the privilege to introduce this very distinguished guest and a panelist. Dr. Shanta is the president-elect of Foxy for the next year. She is a senior consultant and a very well-known laparoscopic surgeon in Hyderabad, but she is known all over the world. And she has held numerous positions in the field of OBGYN and gynecology, as you can see in this slide, which really provides a brief glimpse of all the accomplishments and laurels and awards she has. We are so very pleased to have Dr. Shanta with us today. And I request Dr. Shanta to take the podium and share her thoughts about how to live, what to do for people who are physicians who are having a practice in OBGYN, and share her thoughts from the Foxy point of view.
Thank you, Dr. Agarwal. It's indeed a pleasure to share the space with all of you. Well, now we were in a phase of lockdown, and now it's going to unlock. Can I have the next slide? But do you think unlocking means that everything is going to become okay tomorrow and then we just start off a practice? Well, it is not so. You need to stop and think. Don't you agree with me that we have to understand that we are going to deal with it for a few more months, hopefully. And that's the reason why we need to actually look back how we are going to relook into our practice. Now, if you ask me as an obstetrician, what is it that I need to think about when I start my practice? There are three areas. One is right from the antenatal OPD to the labor room and to the operation theater. These are the three areas which we need to look at when we start our practice. Can I have the next slide? So we have had our friends who have actually talked about triaging and everything. But remember, when we are going back to the OPD, please do a bit of change in your routine OPD practice. We were used to having people waiting in the OPD, huge numbers, 30, 40, and some patients used to be more. Now it's time that we modify. We have an airy room. We remodify our AC and minimize the clustering. Make sure that you give appointments and your patients come by turn. And of course, they have learned about the distancing and everything. Remember to clean your basic instruments like your ultrasound, the colposcope, the scale, fetoscope, stethoscope, everything in between patients, and only use disposable paper rolls and covers. Don't use the exotic cloth things on your OPD. Can I have the next? I think now the time has come that we actually revert to looking how basic is the basic requirement. We go back to the previous school of thought, minimum contact, have only 4, right at 12 weeks to 20 weeks to 28 and 36 weeks, unless otherwise if the patient is having some complication. It's time that we actually start more of this telemedicines, the virtual prenatal care visits. So it could be video conferencing, teleconferencing, so that actually the patient connects with you and you don't have direct physical contact with the patient. That will minimize the chance of any overexposure to unnecessary infection or something. Can I have the next slide? Can I have the next slide, Dr. Agarwal? Well, the most important is educate your patients. Home monitoring where it is possible. Simple things like the weight and blood pressure can be done at home, and all the cases, please insist on daily fetal movement count. Tell them to make sure that they count the fetal movements. If there is anything wrong, let them get back to you. And when you look at the FIGO and the FOXY guidelines, now they say that minimum only 3 ultrasounds, one at 12 weeks, the other at 20 weeks where you do a TIFA, and 32 weeks in uncomplicated patients. Please don't go and do a lot of those growth monitoring ultrasounds at this point of time. Can I have the next slide, please? And the most important is how you check your indoor practice. You need to upgrade your facilities, like have more of the single rooms, relook at your aircon, and ideally, if you can do a pre-procedure testing for all, that's the best, but it varies. And aggressive use of disinfection in your indoor hospital practice, very important. Can I have the next slide? Can I have the next slide? And the most important thing is changes in your day-to-day practice. Remember, friends, we are unlocking for the practice. Don't unlock your wardrobe. Wear simple clothes to your OPD. If possible, please don't wear jewelry. Leave all your exotic jewelry and watches at home. Take only one pen. Have the one water bottle and food, which you can leave in the car ideally. Please don't use lifts. You can walk up to your OPD, and remember to wear your mask, your goggles, and the face shields. Remember, when you come back home, you have to clean your hands, remove your footwear, and better that we take a bath after we come back from OPD home so that we don't carry back any infection back home. Can I have the next? And the most important thing is you need to actually make your patients aware about what is it that they need to tell you. Make your patients call you up before they want to come to the unit, so that they call in advance and so that you're prepared. We have heard about about the triaging and the PPEs, and you know your patient is going to come, your staff is prepared, and accordingly we can have the patients come to us. And if infected patients, please preferable to have an isolated labor room, and don't have all this water baths and all the other techniques, the natural birthing process and all. Please stick to the basic obstetrics which we have been practicing. Can I have the next slide, please? And the other thing is your operation room. You need to relook at how you are having your OT room. Minimize the personnel in the OT. You make sure that PPE is there, and of course your patient has the mask, and don't have too many people in the OT. You have the minimum, your anesthetist, your one scrub nurse, and one assistant. And even when the baby is there, you have this proper barrier nursing, which is very important in the post-operative period, so that in case if there is if the mother becomes infected, so that we don't have the mother to child transmission to breastfeeding, though the current guideline says there's no such risk. Can I have the next slide? Yeah. So friends, you remember that we need to upgrade ourselves with the simple thought process that we have to unlearn what we have learned. We have actually learned to be very sophisticated, doing very hi-fi things, but now time has come that we need to look at very simple techniques to keep our patients and ourselves safe. So don't worry, go back to your obstetric practice, and I'm sure that this phase will also pass. And remember one thing, there are some nice videos of donning and doffing the PPEs, which the ICMR and the FOXY guideline has also given. Make your staff look at it so that, and you also, we never knew what the PPE was, what's the difference between an HIV kit and what's the difference between the PPE. So we need to learn these things which are very simple, and I'm sure that we'll be able to do it. And Foxy has come out with our GCPR. The second edition has been released. So all of you can actually download it and go through it. And any doubts you have, you can always refer to it, ask your colleagues, and I'm sure that is no nuclear science that we can't deal with. So I'm sure all of us are going to do good obstetric practice in the coming months.
Thank you,
Thank
Dr.
you.
Shanta. Thank you very much. It was really a most wonderful presentation from someone who is the doyen of the field in the entire India. And you put it so clearly and so nicely. And I think your message was very positive, uh, trying to provide the tools, but also to keep the spirit high. And that is really a very important way of conveying it. So I am really, I think we are all very grateful for your message and for your presentation. Thank you so much. Thank you.
Thank you.
Now we move on to our next distinguished speaker. Uh, and I have the honor and privilege to introduce Dr. Krishna Kumar. Dr. Krishna Kumar is actually a very well-known surgeon, a person who has a laparoscopic surgeon and endoscopic surgeon, who is president-elect for this very prestigious society called Indian Association for Gynecological Endoscopic Surgeon, or it is also called as IAGE. He is a accomplished surgeon who's going to share his thoughts about laparoscopic surgery and IVF practice, which we would like to hear from him. So I want to invite Dr. Krishna Kumar to kindly come and take the stage now.
Thank you, Dr.
Krishna Kumar.
Agarwal. Thank you, Dr. Agarwal. My sincere thanks to the Global ART Forum and the organizers of this great event for including me in this presentation. Of course, as Alpesh already said, just unlocking means it is not, floodgates are not going to be open. Whatever guidelines I say may keep on changing. So right now, certain tips so that you can just sneak in and then start step by step your surgery. My next slide. Can I have my next slide? Yeah, we know that today women care is equal to endoscopic surgery. Last 2 to 3 decades, we have all seen the advantages of laparoscopy and hysteroscopy. Though there are no data translating surgical exposure to definitive risk to the operating team or to the patient. Neither, as far as corona is concerned, right now there is no evidence to safety. So we have to have a balance as to how to protect the healthcare team and also the patient. Next slide. Surgery and viral transmission is something we are talking about, but historically there has been no proven ability for a virus to transmit during a surgical treatment, whether it has been open or there has been laparoscopy. And there is no societal consensus on either limiting or restricting. However, there is an expert consensus on the certain modification of standard practice which we are doing to minimize that fear and minimize that risk of transmission. We have to follow certain basic guidelines. Next slide. Now, if you consider laparoscopy, it is always known that it is much more safer than laparotomy because the stay is less, the recovery is faster, and the survival is also better. And it's a very self-contained operative field with very less possibility of spillage of fluid and tissues to the operating staff. So definitely is much less riskier as far as this particular concern is concerned. And not only you and your staff are at much away distance, which is requiring of what we call as physical distancing these days. You are away from the patient, and even in the OT, you are much away from the staff. So you are definitely as a much lesser chance of exposure. Next slide. Now, definitely in a COVID-19 positive patient, there is no doubt that laparoscopic surgery as of today, you are not supposed to do. That patient should go for open laparotomy. Patients who are otherwise unknown COVID status, definitely all those screening strategy which has already been mentioned, and whatever the testing protocol localized to your specific to your area of practice or where you're practicing should be followed before you embark upon surgery on that patient. Next slide. Next slide. For hysteroscopic surgeon, it's fairly a good news. Definitely, hysteroscopic surgeon does not require too much of aerosolization in the operating room. So that is where hysteroscopic surgery you can do many a time in ambulatory settings without much anesthesia or under regional anesthesia. But if you are using hysteroscopic surgery for your practice, try and use energy devices which are mechanical, which do not produce smoke. Today, good scissors, good graspers, and even mechanical morcellators are available for treating endometrial polyp or the submucous fibroid, a great relief and avoiding hysterectomy. But you have to also see that you expedite the patient's discharge, and definitely the patient, if she's kept in the same table, it is better. If you're changing the room, decontaminate the room. Next slide. And next slide, please. And no, there's been a jump. And yeah, if you're used to hysteroscopic surgery and you want energy, you can use bipolar, and you are using within a liquid environment. So definitely aerosolization does not occur, but the fragments and debris which get accumulated inside the uterine cavity, make sure that the resectoscope has a good suction attached and continuously flows into the bottle rather than it falls outside into your OR or onto your lap, and avoid too much of insertion and removal of hysteroscopy. So that will create more spillage. So definitely, if you follow these practical tips, it will help a lot of avoiding spillage. Next slide. And anesthesia, I said, it is very simple. You don't require general anesthesia. Regional anesthesia is more than enough. And we do not know about the aerosolization of carbon dioxide. It has not been proved. Now, just to take you through the other energy devices which we use and which says just don't use those energy. Electrocautery fumes are about 0.1 microns. Laser produces roughly about 0.3, and it is definitely known that ultrasonic brings out the maximum size, which is about 0.3 to 6.5 micron. But these are just size of the particles which are generated, not that these are carrying viruses. Next slide. Yeah, there has been too much of jump. I think a couple of my slides have been gone. The previous slide, previous to this. Oh, my intubation was there. See, generally one practical tip is during your laparoscopic surgery, the anesthetist has to take a very practical way of intubation. Today anesthesia intubation boxes are available. You are supposed to use video laryngoscope, preferably with the disposable blade, and also make sure that during the intubation, only the anesthetist and one helping nurse is there. The rest of the surgeon and the operating team waits outside the operating room and enter 15 minutes after the anesthesia is given. Next slide. Next slide. Yes, general precautions is definitely when before starting the surgery, check that all the trocars have no leak. The valves and the washers should be absolutely fine. Don't try to use trocars which are reusable, or once a disposable one is used, don't try to reuse them. But direct entry may be always better because you're not instilling gas into the abdomen. So during insertion, always there is a gas leak. So I would prefer direct entry. Use lower pressure setting, about 10 to 12 millimeter. Reduce too much removal and insertion of instrument during your surgery, during the inside the trocar and outside the trocar. And if you have to retrieve tissues like ectopic pregnancy, make sure that you deflate the abdomen totally and then only retrieve the tissue. And before reinserting the trocar, do not start the CO2. enter and then only start, keep the valve closed and then only start your carbon dioxide insufflation. And in hysterectomy, which we all do, before removing it or before delivering it from the vagina, make sure that you have totally deflated the abdomen and then only remove the specimen. Next slide. Now, this laparoscopy and viral transmission, there is absolutely no evidence right now to support that laparoscopy definitely transmits viruses. If at all you're used to energy devices, you use the bipolar, and I would prefer the vessel sealers because the aerosolization is much less. Minimize operative staff exposure, all those precautions which have already been explained. Full PPE for all your staff and self and the anesthetist is absolutely required. And risk of transmission or the presence of coronavirus in the peritoneal fluid is not yet established. It's very unclear. Next slide. No, previous slide. Okay, there was one thing which aerosol about the filters. I think you should, one or two of my slide have gone missing. There are a lot of closed circuit evacuation system available called as the ULPA filters. They filter up to 0.05 microns, and coronavirus, we know it is about 0.14 to 1.6 microns. So definitely even that corona can be filtered by this filter. And in case you do not have your closed system, there has been your suction machine, you can attach the regular anesthetic filter which are there, which are fair enough. Of course, evidence is still not that this will protect you totally, but this is the way if you do not have your suction apparatus or the closed suction system. Next slide. So definitely nothing in the life is to be feared. It is only to be understood. Madam Curie has said, so my message to you all is we will definitely find a way forward for this, but start slowly. Don't jump into surgery tomorrow. Start with hysteroscopic surgery. Do simple surgery where there won't be much gas utilization, much leakage. Start with routine hysterectomy and keep some surgery like myomectomy after 3 or 4 months. Thank you.
Thank you, Dr. Krishan Kumar. Wonderful presentation you have done, and I think you have clarified how various types of laparoscopic procedures can be started and what precautions need to be taken. I think it was a roadmap that and a blueprint for all of the practicing physicians to get back into the practice in a very careful, thoughtful manner, taking all the precautions. But as you said, nothing is in the life is to be feared. It is only to be understood. I think that is really, I think the central message is if we really take a thoughtful, careful approach, we can be safe. We can really take care of our patients who really are waiting to be taken care, and maintain the profession that is so important for the entire society. So Dr. Krishan Kumar, thank you so much. And my apologies if some of your slides were missed, but you provided wonderful presentation. Thank you once again. So now moving on, we go to the next speaker here. Actually, we will skip Dr. Prakash because he is in another webinar. So we will go to he will join a little bit later. So we are going to reshuffle, and we have our next distinguished.
Dr. Agarwal, I am there.
Oh, you are there. Oh, okay. Sorry. Dr. Prakash Trivedi is well known all over the country. He is the current president of Indian Society for Assisted Reproduction. He is a famous and well-known surgeon, laparoscopic surgeon, and reproductive surgeon. And he has held several positions as president of some of the most prestigious societies within our country in India. So I know he just finished another webinar, so we are pleased to have him back, and we would like him to share his thoughts and continue this very valuable discussion. Dr. Trivedi, we are allotting 6 minutes plus 1 minute for each speaker. So kindly begin your presentation. This stage is all yours now.
Yeah. With your permission, I have 5 slides only, which I will be going through. And if I can share, then add those photographs which you were telling. But I'll try and be brief. I just came from a webinar with 1600 plus people. And my purpose of the talk, as I was mentioning to you and Dr. Sunil Jindal, is a little bit different. As we went into lockdown, and then we started wondering that when there is a unlocking, how we are going to do, and we started this preparation much earlier. My secretary and receptionist and PRO all staying in Dombivali and Borivali and far off. So they managed to inform all the patients, whether they were antenatal, whether they were IVF, whether they were fibroid, whether they were hysterectomy, whether they were keen to conceive. So there was a questionnaire which was asked to them, and they were told that 11 to 2 on a particular day, I will be available for personal consulting or video consulting or so-called they remaining outside. And at the same time, they were given a questionnaire so that we get an idea whether anybody of them are affected or who is the accompanying person coming, and any of the relatives and all. Now, this exercise proved very useful because even in last month, we used to have 6 to 8 patients spread over 3 to 4 hours in an extremely tight rope fashion. And that was useful because all these people felt that they are being attended, and they came from a far off distance. As they were carrying our file, nobody stopped them. So you have to, the secretaries and all separated their appointments half an hour apart, and taking care that we give adequate time, and there is changeover time proper so that we can clean the consulting table, the sonography machine, etc. And all the important findings and investigations were advised, and we came with a ready with the patient who was taken care of. Later, if I get 1 minute, I'll show how the patient and all were screened by sharing the screen if there is a time, if there is time. Next slide. Yeah. Now, we divided because we have a typical group of patient. In the normal circumstances, 5 p.m. we used to start consulting, it used to run till 12 o'clock. This was not possible in this time. So we have our antenatal patients, we have our patients who are there for surgery, which can be planned for excessive bleeding, IVF patient, infertility patient. So we made it very clear that it's only an emergency patient, and we did have ectopic, we did have acute appendicitis, we did have torsion and various other things. Now, when we have any of this patient which it comes as emergency, there is no option. Many of the stimulated patients who were just round the corner for an embryo transfer, when almost the thing was about to be called, we managed to finish it, but majority of them were frozen and were told that we will do at a suitable time. For a patient who needed a surgery, because you have to remember there are certain cancer patients, certain patients of multiple fibroid. I had to do one yesterday wherein there was so much of bleeding, and they were scheduled on 12th March and the clamp down came. So ultimately, what we do is we do a swab test 3 days prior, quarantine them or isolate them, and do the surgery in laparoscopy, as I will be telling what precautions we take. After everything is fine, she goes home within 2 days. And on 7th or 8th day, when she comes for dressing, that's the time when we do IgG and IgM. Obviously, a clear permission is taken that hospital has taken due precaution. Nobody in the hospital at present is having COVID. And we anticipate from your history that probably you are not having, and you can be in a window period. So emergencies were handled, and apart from emergency, only occasional cases wherein patients were in too much of morbid pain or bleeding, which was really worried. As I mentioned to you, we ask even the AHGL, for example, whether the anesthetist and the medics who are there inside the OT or inside the IVF lab, should we have the swab test done? And that was important thing which we got from one of the places in America, that if we have 1,000 kids and we'll use 200 for our asymptomatic staff, then probably we'll go on less resources. The answer was very clear. Only a symptomatic person is to be taken care. Elderly anesthetists and other people were told to rest at home, and we saw that they are taken care. Next slide. Once they are in hospital, even for bleeding with pregnancy, or then the temperature check is done for each and every person. Sanitizer is given, mask and all is checked, and a fixed person gives. We have a very large waiting room, so easily people can stay away from each other. Every aspect of the room in the hospital or in the consulting is properly cleaned. The basic facilities are provided if there was a patient who was likely to be admitted. So they didn't have to go anywhere for their food or their primary need. Patient and only one fixed relative. Adequate amount of masks, sanitizers, sterilium, etc. was kept. Only optimum stay was done because we have some of the IVF patients who were bleeding, and we had to keep them in the hospital but take proper care of them. If anybody had fever, cough, or any suspicion, then obviously isolation was the norm. If anybody had COVID positive, then they were sent to a COVID hospital rather than handling. Most important, we felt that due precaution is to be taken by the person who is serving food and the nurse who is attending. So there is one nurse per patient. So there is not too many people. Doctor also one doctor, either the chief consultant or one doctor who looks after. Uh, Simple OPD procedures were done on OPD basis. Our OPD is on the 5th floor and the hospital is on the ground floor. So it could be managed if there was a need. Second, patients were, once they are shifted to OR, the anesthetist is taken, they have intubated, and then the team enters inside. Anesthesia itself has 3 filters, and that if I can show the film, I will show 2 filters in the, because I've done a post of anesthesia, so I know in detail how that usually works, so that there is no risk to the machine, no risk to the patient, hood is there, and no risk to the anesthetist. Next slide.
Um, Dr. Trivedi, just respectfully, you have just 1 more minute because we have many other speakers and we are running behind.
No problem. Just
Please try to wind up.
yeah. Now, OT, as I told you, we have to be very. Now, only one myth I want to remove. COVID is a particulate material which goes into the respiratory tract. Through respiratory tract or through GI, it cannot aerosolize in the peritoneal cavity on its own. So that fear of doing laparoscopic surgery in negative patient, in cold patient, is ill-founded if they are negative. And CO2 which comes and which is used through filter and suction which are used to filter and negative filter probably really doesn't increase the risk of laparoscopic surgery. So you have to weigh the balance and then you have to decide, and special care has to be only taken while intubating or extubating, because every surgery you cannot do under spinal dressing. Next is the last slide, I believe. Now, infertility and ART, this is the major area wherein we can only do 25% of our work, like a frozen embryo transfer and some other work. A lot of planned work has to be shifted for obvious reason, because you don't want, obviously, normal patients are getting pregnant during this time, but we don't want to contribute. And we have to be clear not to have myths and unscientific fear. We are living on an edge of lot of wrong messages we are getting even through webinars. And we are sometimes missing that what is possible that we can do to serve the women patient when it is possible. I think so. I finished my slides.
Thank you very much, Dr. Trivedi, and I'm very sorry to rush you. But your presentation in its entirety is being recorded along with the slides, so it will be available. And Sunil is going to explain towards the end how the delegates can access it. So, and certainly it was wonderful what you have told. So I appreciate you joining and sharing your experience and your thoughts with the rest of the public here. So thank you very much. And now we move to our next speaker. Our next speaker is Dr. Jayant Sharma. Dr. Jayant is really, I think, the most famous person in India. He is the president or secretary for Indian Medical Association. He is also holds very important positions in many other societies and clubs, which you see here. We invited Dr. Jayant to provide, because he represents the umbrella group of Indian Medical Association of all the physicians within India, to share his thoughts from a more broader perspective, which really are what we are looking. We are not only restricting our discussion to the field of ART or laparoscopic surgery, but to look at it from a broader perspective. So Dr. Jayant, kindly take the stage and give your presentation now. Dr. Jayant, are you there? Okay. We will try to track him. I'm sure he was. Are you there?
Yes, sir.
Okay. So Dr. Jayant, now you can begin your presentation, sir.
Good evening, everybody. My topic is role of IMA during unlock. So next slide, please. I am basically urologist, and we are doing in field of ART also. My wife is a gynecologist, so with her all people have talked about ART and what to do, what not to do. Sir, just a minute. As official of IMA, we need to look at the perspective of like people, those who are running solo clinics, small hospitals, bigger hospitals. Every day there is a bombardment of different guidelines from different societies, even our WhatsApp universities, and people are thoroughly confused. There are so many do's and don'ts, ifs and buts. Our role at present is to educate our people how to deal with situation, because it is going to become a way of life for quite some time now. So role of IMA during unlock is to educate clinicians regarding recent guidelines issued by government agencies, ICMR and all, not to make them confused about different other guidelines, what to do, what not to do. To make our own guidelines, and every hospital has to make its own SOPs according to their needs and requirements. We are here to coordinate between our doctors and government. Any information, any problem with doctors, we need to communicate it with to government, and whatever guidelines, whatever directions we get, we communicate it back to our doctors. In our hospitals everywhere, it is mandatory now to appoint a nodal officer for infection control for COVID, and we need to get a regular training. Need to train ourselves and our hospital staff. My submission is don't panic. It is rightly said, it is not the end of life. Sir, everything has been said. Wash your hand at entry, educate your patients and their family members to wash their hands or use sanitizers, thermal scanning, and so many other things. The next slide, please. Now, biomedical waste management has little bit changes how to use bins, how to dispose these biomedical waste. For cleaning staff, we need to use heavy duty gloves, gum boots, and masks and everything. For cleaning of our hospital, it was 2 bucket norms, which you can see on internet. You will find it, or people are using in our hospital and everywhere. Now it has become 3 bucket system. Use of sodium hypochlorite, alcohol-based hand rubs, and other disinfectants. They are, I mean, same for operation theaters, triage, waiting areas, rooms, and other areas. So next slide, please. People have already talked about social distancing in clinics and hospitals. Allow only one attendant, if possible. Patient can come alone. Make an infection control. These are all guidelines given by government to us, and we are propagating them to like all our members in India to make infection control committee and regular monitoring at the facility. Regular decontamination, that is very important. Disinfection of surface, instruments, OT equipments and other equipment, OT cylinders and ambulance accessories. The decontamination and disinfection of OT, there are different decontaminant available, but sodium hypochlorite is still gold standard. For waste management, there are certain guidelines which have changed, and time to time they are giving us these guidelines and we are giving them to our members. Proper data management and reporting. Reporting part is very, very important. Sir, if you are having a single case in your hospital or 10 cases or one patient in your OP, we have to inform authorities. This much of patients, these patients we have seen, and these patients are their phone number, their address, and their age. We have to inform authorities. There is provision of 10, somebody was talking about the 10 points. There's a 10 points chart so that you can decide which patient you need to send for swab test and other tests. So next slide, please.
I think that was the last slide.
All right. There was one. Okay, sir. So my part is very simple, but I'm open for, because we are having constant inputs from government. So probably I will be able to answer few of your questions. If somebody are going to ask later, I'm always here. Thank you, sir.
Thank you very much, Dr. Jayant. You were very concise and precise, and your outlook and your guidelines and your thoughts are very important because it represents a very important aspects for our group of delegates who are attending, representing the Indian Medical Association. So thank you very much for enlightening everyone and sharing your knowledge and your experiences and providing very beautiful information. So now we move to our last speaker of this program. Of course, we save the best for the last, and this is Dr. Anupam Sibal. Dr. Sibal is the medical director, group medical director of Apollo Hospital Group, which owns, I believe, a very large number of hospitals, maybe 100 hospitals all over the world. And we are very privileged and honored to have him here with all of us. and he is going to represent Apollo, which is one of the most prestigious brand in corporate hospitals in all over the world. So he is going to provide his insight in respect to how to unlock a corporate hospital along with this pandemic of COVID. So, Dr. Sibal, welcome. And we would like I don't think you have any slide. I know you told me that you are going to share your thoughts directly. So please take the podium, and we look forward to hear from you.
Thank you, Ashokji. Thank you, Sunil. Good evening, friends. Good morning to Ashok in Cleveland, and good afternoon to Alpesh in London. Namaste to everyone. Some of us had read this wonderful book by the Nobel Prize winner author Gabriel Garcia Marquez, Love in the Time of Cholera. Who would have thought that we are going to have to define how to practice medicine in the time of COVID-19? Our lives have turned upside down. On one side, we have to care for patients that we've looked after for years and decades, managing their needs without actually being able to see them physically, look at developing guidelines for several of these patients. And on the other hand, we have to grapple with COVID-19. And many of us have been in the private sector managing patients. It started off with setting up facilities for diagnosis, which of course is also something that consumed a lot of time. And then we moved on to setting up facilities, setting up ICU beds, setting up rooms with a negative isolation, getting the SOPs in place. So working with different specialists in getting the COVID-19 protocols. And very importantly, motivating the staff. And for some of the junior doctors in our system, this is really their first brush with war. This is their first time on the battlefield, and to keep them motivated, to get them to spend 6 hours in PPEs without having bio breaks is not easy. So a lot of energy and time has been spent doing that. But I think now we've come to the time where we have to accept that there is going to be a new normal. COVID is here to stay. It's not going to be something that's going to go in a month, 2 months. We really need to prepare for the next 6 months, 1 year. And we really need to look at how is it that we're going to unlock our facilities. So a lot has been said about IVF, about nursing homes, small hospitals, about obstetrics, about gynecology, the IMA perspective. So what I'm going to do is really give an overview of what is it that we are doing at Apollo, what is the corporate hospital group doing, and some of these ideas or thoughts might be something that you want to consider. So let's look at Khulja Simsim from a corporate point of view. So I think the first thing for us is to realize that I think we are living in a mind of major fear psychosis when it comes to the community. So when I say unlocking, we can unlock the hospital tomorrow, but are you going to get any patients? There is absolute fear psychosis that has permeated into the deep recesses of the cerebrum of our population. And you can't really blame them, because just look at the infodemic. So 3.4 million patients, but please type COVID-19 on Google. You get 2.6 billion results. 2.6 billion results. And this disease is only 121 days old. Now, we've known diabetes since 1500 BC. And type diabetes, and you get, and I did that recently, you got 620 million results. So something that we've known for 3,500 years has only 620 million results, but something that we've known for 121 days has 2.6 billion, nearly 4 times of that much information available. So this is what everybody's being fed on. There are 30 million WhatsApp messages that go out every minute in the world, and I'm pretty certain that half of them are about COVID. And virtually all of them are about negative impact of COVID. Now let's look at clinicians. Let's look at us as managers. Go to PubMed. There are 7,700 papers on COVID-19. So this disease is 121 days old. So that's 64 peer-reviewed papers published every day. Now, is it humanly possible for anyone to read 64 peer-reviewed papers and then to make sense of it? And then patients will call you and say, chloroquine ke bare mein bataiye, tell us about remdesivir, and tell us about plasma therapy, and tell us about the hypothesis about, the problem with oxygenation and how all of you have been looking at it in a very different manner. If we look at the candidate vaccines, there are what, 115 candidate vaccines. There are 138 therapies. There are 180 clinical trials going on, and 150 are planned. So, we have the pandemic on one side and we have the infodemic on the other side. The average Indian is caught between the two, and honestly, at this point in time, is petrified. They don't want to enter a hospital. They don't want to enter a clinic. They don't want to enter a nursing home, and it's not their fault. So unless we address fear psychosis, and I think this is where all of us as clinicians, managers, IMA, all bodies, all professional societies need to start a campaign of removing the fear psychosis. That's the first step in terms of unlocking. I think we've gone overboard. And a lot of these concerns that people have are really unfounded. Point number one. The second point that I want to make is that we as clinicians and leaders in healthcare have to change our approach, and this approach has to be positive. So if we are not positive, our team is not positive, our workers are not positive, our nurses are not positive, we're going to have a problem. So I think we need to spend a lot of time motivating. Demotivation is going to seriously compromise our functioning. So we really need to address concerns that everyone has, answer the questions that they have, really do this in a very open fashion, and spend a lot of time and effort doing that. A lot has been talked about sterilization, decontamination. So I'm really not going to get into that. PPEs, how to open the OR, how to open endoscopy, labs, ER, outpatients, ICU, all the other areas. But what I just want to emphasize is that there can be no area that can be left out of the analysis in terms of sterilization, decontamination. From the parking lot to the flow of the patient through the facility, to the different areas that that individual will go, to going out, everything needs to be studied. And this is something that every manager, every executive has to spend a lot of time looking. There cannot be any cracks. We cannot have a breach. One breach will create huge problems. We are seeing that. If one health worker or a doctor becomes positive, then contact tracing, everybody going into quarantine. And just imagine that it's a small nursing home, and if 1/3 of your staff goes into quarantine, how are you going to open? And you're gone for 14 days. And what if you have patients? So there can be no opportunity for breach. So we really need to fortify very, very well. And I think a lot of time and effort needs to be done. And that's what we've done at Apollo. We've had multiple groups, infection control, microbiology, for every specialty, the clinical side, the lab side, the therapy side, the blood bank side, all of them, multiple groups, lots of inputs. And then we've kind of created a way forward in how is it that we are going to unlock. So that was point number 3 about sterilization, decontamination. Point number 4, it has to be staged, it has to be staggered. You can't really open everything tomorrow. It's not going to work. We're going to end up having a problem. Just like the government is doing a staged opening of the lockdown, we need to decide. We need to decide what is going to work for us in terms of what services can we start today, what services can we start perhaps a week later, what can we do a month later, are we going to be focusing on outpatients, are we just going to focus on interventions, what is it that we really need to focus on in terms of the need of the community, what our strengths are, where we believe that there is no chink in our armor. So that is something that I think, again, we really need to focus a lot in terms of readiness. And point number 5 is that let's please define the new normal. Now, who would have thought that all of us will be meeting across time zones through Zoom? I mean, none of us has attended a conference for 60 days. I have never been in my house for the last 17 years for more than 7 consecutive days. So, life has changed so much. Who would have thought that we are going to be able to come together the way we have? So I think we now need to define the new normal of clinical practice. Honestly, we really need to look at virtual consults, and those who don't embrace this are going to be left behind. A lot of patients are already figuring out that for a change in medication, you really don't need to come and see a doctor, and the lab report can be sent to you. And all you're going to do is tweak medication, might examine, might not examine, take a 45-minute journey one way, see you for 5 minutes or 10 minutes, wait for 20 minutes, and then go back 45 minutes. You're spending 2.5 hours to be told that you need to change the dose of warfarin, which could be done on the phone. So if we look back, a lot of consults can actually happen virtually. We are going to have to move away from physical consults to virtual. The sooner we embrace teleconsults, the better it is. The Board of Governors has already passed rules and guidelines about that. The second thing is we're going to also have to embrace technology in terms of teleradiology, telepathology, and there are solutions available, EICUs. And I think this is really here to stay. It's like, why wasn't there so much excitement about the swine flu and how come we were able to function? Because surprise, surprise, there was no WhatsApp. WhatsApp was born a few months after swine flu. A pandemic was declared. Now just imagine how the world is today with technology. So we're going to have to embrace it. It's already changed the way we lead our lives. It will change medicine. The sooner we do it, the better it is. I think there's an opportunity for us to re-look at every single process, how we register patients, how they walk through the facility, how do we transfer from one unit to another, how do we keep them in the OR prep area, how do we keep them in recovery, what is the turnaround time, how long does the discharge process take, what are the post-discharge follow-up instructions, how much time does it take to turn around patients between two cases in the OR? How much time does someone has to wait for an MRI? These are questions that we've not had the time to address because all of us have been so busy working 24/7. Now is the opportunity for us to reassess how we are bringing in new systems, because I think there is clearly a greater opportunity than ever before of becoming smarter. I think the key is going to be efficiency. The hospitals and the systems that are going to be more efficient, that are going to respect the patient's time, are going to make sure that the experience is more comfortable. It follows the norms of social distancing and minimum physical contact is going to decide on who succeeds and who is going to struggle. And because this is something that is going to be around for a year and a half at least, if not more. So I think we have been given a fantastic opportunity to become more efficient. And I think that's something that we must take and approach with an open mind. And if we do that, I'm sure we'll be able to find solutions and become more efficient than we were, say, 3 months ago. I think what COVID-19 has done is give us an opportunity to pause, to stop, and to think about how is it that we can actually become better at what we do. But more importantly, it's also given us doctors as an opportunity to spend some time with our family, which we totally ignored. And I want to highlight the work-life balance, which I think is totally skewed in our cases. We've never done this properly, and it's an opportunity that we have. We've missed weddings, we've missed functions, we've missed birthdays, we missed all of these important things that nobody in any other profession misses, because for us, our patients have come first. And I'm saying our patients will always remain first, our families will always remain second. But I think we need to recalibrate and get our work-life balance. And to be able to do that and to maintain that, I think we have to get smarter. We have to delegate more. We have to organize and we have to supervise. We don't have to do everything all the time ourselves. I think this solace that we have now found in the arms of our family members really needs to become a way of life. COVID-19 has taught us that we have this amazing ability to find solutions, whether it was unraveling the genome of this virus in a few days, or to look at therapies, or to get trials going, or to get the vaccine trials going, which normally take a couple of years in a few weeks. It has just shown what the human mind is capable of. It has shown that how we can collaborate together, learn from each other, have an open mind, look at guidelines that are developed in another part of the world, adapt them, adopt them, and actually learn from this whole knowledge base that has been created. And I think it's very important for us to derive a great deal of satisfaction for how well we've handled this, and that with our spirit, we're going to handle this really well. And I end by saying that with the kind of spirit that we have as Indian physicians, and we have seen that we've established the Global Indian Physicians COVID-19 Collaborative across 45 countries, where there are Indian physicians. We meet once a week, and we've seen how Indian physicians have led from the forefront. Many of them have lost their lives as well in this battle. But the work that Indian physicians have done globally is being increasingly recognized. And I think we need to draw energy, positivity from that spirit. And we can, we must, and we will conquer COVID-19. Thank you very much.
Thank you so much, Dr. Sibal. Your presentation was the hallmark. It is so inspiring, and it is so much things that you had discussed and shared, which were so very different from so many other speakers. But more importantly, you have given really a roadmap of how the physicians all over India and in many other parts of the world can really regain the ground that they have lost because of COVID-19, and given very clear instructions, some of your viewpoints in terms of telehealth, specifically in terms of virtual visits, have become a standard practice here at the Cleveland Clinic, which is the second largest hospital in the entire world. We see about 10 million patients each year. So we have adopted within our own urology institution the virtual visit, which as in India, many of the physicians were not very comfortable in the beginning. But we had 2-3 doctors who served as a champion. Every single day, they are teaching, training, explaining how different tools, different types of devices can be used, how you need to go about doing it, how to bill the patient, how to schedule the patients. So there was a continuous tutorial by their colleagues, which were nominated by the department. And that has led to much more comfort and ease among the staff and faculty about adopting this technology. And you are right that these technologies are going to stay here for a very long period of time, and it will become a way of life. So we need to look at it in a way that these things which have been thrust upon us are used as an opportunity for us to really become more smart, more efficient, and not look at it from a negative point of view. Of course, the pandemic is going to go whenever the time will come, and I think a lot of smart people are working all over the world to develop the vaccine and medication. But for the time being, I think we have to be very smart, knowledgeable, and open the services, as you said, in a phased manner, and not try to think that we can go and start the entire unit, the entire hospital, the entire nursing home in one go. I don't think that will be possible, as you rightly said. So with these words, I want to thank you and all our speakers. And now I want to give this podium to Dr. Sunil to begin the question and answer session, which is our next part of the program. So he will moderate the question and answer from our delegates who have registered to this webinar. So Sunil, the dais is all yours now.
Thank you very much. Thank you very much. Thank you, everybody. And can you imagine, from the last count which I received, we've had about 1,872 people who are there, who have joined the webinar. One. And can you realize that throughout the meeting, there have been very few people who have left. But the crazy thing is that we have spent 1.5 hours, and we would need at least 1 hour more for the question and answer, only for the reason that I have received till now 66 questions. And 66 questions are pan everybody. So I really feel it's going to be fantastic. It just will be fantastic. And Dr. Anupam Sibal, when you said of clinical trials going on, I just took out the data. And can you go into it that we have about 783 trials in the US, in the EU 155 trials, and in India 49 trials. So India is the 3rd country with the maximum trials. And another beautiful thing, like just you said, that the whole scientific community, which never collaborated before, has collaborated, and about 52 trials are close to human trials, which has never happened before. This is the human spirit, and this is the beauty of the whole thing. So I think I'll start the question answers, and there are a lot of questions from everybody, and I'm having a tough time in choosing the best questions or what to ask. I would like
Sunil, I think it'll be good to target the question to a specific speaker so that it is easier.
Yes, I would do that. I would do that because the questions also are targeted by people to a specific speaker, and they would be proper for somebody as well. Now, the first question is to Dr. Shanta Kumari. Dr. Shanta Kumari, you're very popular. My goodness, where are you? You're very
right
popular. There's so many questions to you, especially from the OBGY. And the first question is, what is the PPE which I need to wear in the delivery room? And which is the PPE which I need to wear in the when I'm doing a cesarean? Is it different? And what extra precautions should my staff take?
Yes. Now coming to this PPEs, as I have told, there are a lot of confusions. This PPE is a 3-layered suit. Sometimes, you may not be having the PPE as per set, like you don't have a package as such. Some of them have some HIV kits and all, but you remember those which an impermeable sheet, the one which will not allow the fluid or liquid of the patient, whatever the liquor or anything, touch our body surface. So it's basically a 3-layered suit which you're supposed to wear for delivering the patient, and you wear your the face shield, hood, your goggles, and of course the double gloves, and you need boot covers. You'll be wearing this typically, remember those HIV kits which we have, something like, but with an impermeable sheet. That's the difference between this HIV kit and the PPE. In actually many of the centers where they have not got PPE, they're doing with these makeshift HIV kits, but 3 layers with an impermeable plastic.
Actually, ma'am, what probably they want to ask, because the question was very long, and the question was, the question was very simple. It was, do I wear goggles? Do I wear this thing?
Yes.
Do I wear this thing?
Yes.
What they want to ask is, do I wear the full kit or can I do without it? That is what she wants to ask actually.
Better to wear the full kit.
Great. There is another question which is very important, which has come again for the delivery point of view, which I would like to ask Dr. Jayant Sharma. Dr. Jayant Sharma, the question is, a woman has come and got admitted to my nursing home. I have done the delivery and she turns out to be COVID positive. Now, will my nursing home be sealed? Will we be quarantined? What is going to happen to us? Dr. Jayant Sharma, please unmute yourself. Unmute yourself. Unmute yourself.
I think you can't hear.
Unmute yourself. Dr. Krishna Kumar, would you like to answer it, please?
No, I didn't listen. You just said, yeah, she has delivered at your place and she is turned COVID positive, right? After the next day. Now it depends on what you were using, during the delivery time and what care your staff took. So today, every patient whose COVID status is not tested, you have to be like suspect COVID only. So take all the precautions. In case you have not taken precaution, you will be quarantined. Right now, the guidelines. Right now, the guideline says that a particular area where if all the precautions were not taken, you have to close it, sanitize it for 48 hours. And those who have come in contact with the patient and they were not, if they are not protected or if they were not protected with full PPE, they have to be quarantined.
See, there is a yes, ma'am.
There's that latest now guideline is if the doctor has used the PPE properly, there is no
quarantine.
No quarantine for the healthcare worker.
Now there is a problem in this, which is happening in every state, which is different, unfortunately.
I know.
Like recently, about 4 days back, about 5 days back, there is this very senior gynecologist in our city, and she examined a patient 3 months old with fever. And what actually found over there was that this patient had fever, got a COVID test done, turned out to be positive. Her nursing home was sealed. She was quarantined. Her staff, which was 28 people, were quarantined. And the nursing home per se was on paper not sanitized, sealed. So the biggest problem which happens is that now no patient would ever further on in the future think of coming to the hospital jisme corona tha. This is the biggest problem. So now, yes, Dr. Jayant.
Am I audible?
Yes, you are.
Yes, sir, this is very clear. every state guidelines are coming from center. They are being given to state, and state are giving them to their officers in different districts. According to their comfort and according to their understanding of those guidelines, they give guidelines further to hospitals and other places. About sealing these hospitals and quarantine.
Dr. Jayant, your voice is not clear. We can't hear you.
Can you hear me now?
No, we can't hear you even now.
Is echoing.
Is it okay?
Now it's better.
Sir, every hospital has to work according to government guidelines. We are demanding for one nation, one guideline. And hopefully, take my word, it may take couple of days, new guidelines will come.
Okay,
Dr.
Dr.
Sibbal,
Sibbal.
understand
Yes, please.
that we are working in the stage of stress. Everybody is confused. And their attitude has changed a little bit now. Initially, they were closer, sealing, sending doctors to quarantine, asking them to surrender their registrations, cancel their registrations, and a lot of harassment.
See,
Yes, sir.
yes, this is a very big problem which everybody is facing in different areas.
Yes.
There could be a different thing happening in Maharashtra. There could be a different thing happening in Telangana. There could be different thing happening, even for that matter, in Dehradun and in my city. That's the basic problem. It is the interpretation of the law which at the local level is being taken in a different fashion, unfortunately.
Yes. And I was having a meeting with one of the senior district magistrate. This online meeting. He was saying that we are getting mature enough now.
Good. Dr. Sibbal, can I ask you, you as a corporate hospital who have 79 hospitals all over the country, how are you taking this particular problem? The problem is a patient comes for a delivery, she comes in emergency, she immediately has, she's tested for, after delivery she turns out to be COVID positive. What would be done at your setup?
So there are 3 points that I would address. I think as Jayant Bhai has said, basically, we need to constantly move towards a central policy. And because health is a state subject, honestly, we have hospitals in like 18 states. And every day we look at, okay, what are the guidelines for this state? And then we have to give advice to our hospital based on our central red book that we have for all hospitals. We have to modify. One day, outpatient sampling is not allowed. One day, no sampling is allowed in the private sector. So, every state has a different, the ground realities are different in every state. So we respect that, but it would really be a little easy if we had a central kind of rules and regulations, because it would make life easy. So while we canvas on that, and I'm sure Jayant and Rajan and everyone else in IMA is doing their bit. Now coming to every patient, I believe in the foreseeable future should be treated as potentially infective. We cannot compromise our health. We cannot compromise the health of our staff, because the consequences, one is about sealing and disinfection. The other is about what you said in the mindset. They're already fear psychosis. And then like you said, wahan pe to COVID aaya tha. So then, they're not the mental block on whether you're going to go to that facility and it was shut down or whatever. So I think we need to take full precautions. And that's why I go back to the point I made, that everyone should very carefully look at the systems in their hospital, look at what can possibly go wrong, look at all the possible breaches that are possible and fortify. And this needs to be done virtually every few days to make sure that no breach happens. Point number 3, if someone turns out to be positive, now again, it's not in our hands. Every state has their own rules on what they're going to deal with that, who they're going to put in quarantine or not. And so there can't be an answer that will apply to every hospital. But I think what is in our hands is to make sure that we protect ourselves and our staff. So have everything in place, because you don't know who's going to be infected, and you don't know who you've delivered today, who 1 week later will turn out to be positive, or maybe 2 weeks later will turn out to be positive. And then as of now, we have the 14-day quarantine rule. So imagine you've delivered someone who's gone home on day 3, and then 10 days later, she turns out to be positive. And again, that whole cycle will have to be repeated. So I think it's very simple. We treat with full precaution all the time, every single patient.
Now lately, the last till yesterday was the way they were practicing here was every patient before an elective cesarean section was being tested for COVID. If it turned out to be negative, the patient was taken in. If it were an emergency, then that patient would be placed in a separate area with PPE till the report was positive. It was positive, negative. If it were negative, she was shifted into the system. If it were positive, she was shifted to the COVID hospital. That area was sanitized. And in case the PPE was worn by those people in that particular portion, then those people were not considered to be high risk workers. But still in this city, they are being quarantined. This is the situation.
So Sunil, let's understand the fallacy of testing. You have 67% positivity with RT-PCR. So what's happening with 33%?
Correct.
You don't know.
You don't know.
I mean, there are no false positives, all right. But the question is, the very fact that someone is negative today does not mean that they might not be positive 4 days later. So we really have to take precautions. But before anything major, it makes sense to test and then really decide on, yes, I feel comfortable in taking on this case, because remember with aerosol, and there was so much discussion about laparoscopy, intubation, a whole lot of things that, one has to be cognizant of. So it's better to know whether someone is positive or not, because then you take even more precautions. But basic precautions, assuming that that person is potentially having COVID, is essential. And we cannot get a false sense of security by having a negative COVID, because 67%, that's the best.
Absolutely. Dr. Alpesh, I have about 20 questions from the reproductive people for you, but I'll boil all of them down into 2 questions. The first question is, my IVF lab is shut down now. I do not know when would I be getting the patients in the future. How do I start and what protocol should I use to start my IVF lab? Should I be waiting or should I put it into the process now?
So my advice is that you need to put it into process now, because theoretically, I will give you an example of how it is in the UK. We are looking to go live around the 20th to 25th of May. And clearly, embryologists are used to kind of shutting down and starting their lab up during the Christmas closure, for example. So I would suggest that we have to use the same protocol as our Christmas closure. Of course, in terms of resanitizing, disinfecting, with a lot more extra caution this time, bearing in mind of how much we know about how notorious this virus is. So I wouldn't wait for having the first patient start stimulation. I would get the lab ready as per the suggestions that have been put forward today with regards to disinfection and sanitation.
The second question, if I could boil down these 18 questions into 2, is that the second question is, what would I do as an embryologist to protect myself?
So protection is both ways. Protection is you infecting other patients and other patients infecting you. I mean, we have some level of comfort knowing that there is no receptors on eggs and embryos. So essentially, the eggs and embryos are not going to get infected. But in terms of how PPE, I mean, we've talked about so much about PPE, but I think somewhere as embryologists, generally we are very cautious in terms of the PPE that we use in the laboratory. We're also very cautious about interpatient handling. We change our pair of gloves, but this time we have to be a bit extra cautious about the change of gloves, the number of gloves we change, potentially even wear 2 or 3 scrub suit changes in a day. But I think it's just the awareness of PPE, putting visors on when we're doing embryo transfers, for example, et cetera, et cetera. So protection is both ways, you protecting the patient and the patient protecting you, and most importantly, during any kind of patient contact, to also ensure that you have the 2-meter rule in place. I mean, in my clinic, I do not now see patients directly. Even if I have to put a gentleman in the production room, which we're shut at the moment. But if I had to, I would be advising patients to be bringing their samples from home. So again, all those little things, just a bit of thought in the journey can eliminate a lot of risk.
I think this will evolve, and there are a lot of questions for Dr. Prakash Trivedi, but I would boil them down and bring them down to about two or three questions together, because that would answer all the questions we have had, and the questions are still coming in. Dr. Trivedi, one of the questions which is being asked by a lot of people is, number one, do I test COVID test for every patient where I need to do a pickup or where I need to do a transfer? First question. And the second question is, what kind of a PPE do I wear in the pickup theater, which would not harm my pickup as well as would be safe for me?
Oh, I think so. We are not doing home pickup. I think so. Most of us who did an home pickup was close to mid-March.
No, Dr. Trivedi, they're asking if they pick up now, because the guidelines are that you can start an OPD if you want to, and you can start the outpatient as well, and you can start pickup. I'm talking of the government guidelines.
Yeah, no. See, what happens is there are three important facts. Government guidelines is one, number of COVID patient is two, number of tests done are three, number of patient missed are the most important thing. So now primarily you have to remember whether you want to take any patient for stimulation, etc. and all, you have to have a clear idea about the history of the couple for 2 weeks. If there is any suspicion, then I would think that I will go ahead and do a COVID test, because it is not that easy to convince anybody to do a COVID test, because it's always a couple. So if you're doing females test, they feel why the male is not done. Number one. Number two is the issue about PPE is a little bit exaggerated, according to me, because we want PPE, some of the PPE in OPD, we want some PPE. Essentially, it's unsterile. So we want PPE. On the PPE, you want additional thing so that it is sterile. So what happens is when you are actually using it personally, you are having PPE, you are having a sterile gown, you are having double glove, and many of the things. There is, if you have to do a pickup, I don't think so you have a choice to just select a HIV gown or just one gown. You don't have an option, but you have to wear both, and which is, to honestly, it is very hot, stuffy. And if you add one more hood to it, it still becomes, so that's a practical problem.
Dr. Sibal.
Yes, Sunil.
How would you take this particular issue, which a lot of questions are being asked, that if there is a patient who comes for an elective procedure, would you like to test a COVID for that person?
I would.
And if it is a scenario, in your hospital like an embryology or a pickup theater, I mean, how would the PPT, like Dr. Trivedi said, it's hell of a job to wear that PPE with the face shield.
So,
and then one gown.
So what I would say is that before elective procedures or what would be essential procedures, we would test. But even if the test is negative and we are going ahead, and many times we will, I would edge on the side of actually wearing the PPEs, because nothing like protecting ourselves and our staff. Because at the end of the day, if God forbid you get it, everybody is going to be asked, you are very knowledgeable, you are the experts. Why did you not take the precautions? Who told you not to take precautions? So I think we have to be very careful about this. And Sunil, if I make a submission, I'm going to have to go in the next 2 or 3 minutes. So if there are any more questions for me.
There are a lot of questions for you, and let me bring them down to 2 questions.
Yeah.
Because the problem basically is that I'm receiving the questions from these people on the WhatsApp, and then somebody's printing them and getting them. One of the questions is, you have all the money in the corporate hospital, but me as a small nursing home, Dr. Sibal, how can you expect me to work with the poor patients? You are talking at the moment of all the PPEs and considering everything, but I will lose all my job to you. As it is, and I'm quoting as it is, please.
Of
I mean,
course.
as it is, I have lost most of my insurance patients to you. And still, if you talk about this cost sensitive area, I don't know where I will go. So Dr. Sibal.
Okay, first of all, please remember that I'm a clinician and I share the pain that every clinician has. And I continue to see patients. So I fully understand what you're trying to say. Secondly, please don't be under the impression that corporate hospitals have all the money. We have all the salaries to pay. A lot of work that used to come has gone. A lot of work used to come internationally, which has gone and is not going to come back for the next 4 months. So, for example, in very sophisticated equipment, the foreign patients were subsidizing Indian patients. So honestly, the problem that we are facing applies to every single person. A person who does not have a nursing home has his own patient base and just a clinic. Think about him. Nobody's entering his clinic. Think about a general pediatrician who used to vaccinate. No vaccination, no consultations. Clinics shut down. So I think each one of us is feeling the pain. The quantum might be different. The impact might be different, but everybody's feeling the pain. My submission to you, Dr. Saab, is that God forbid someone in your team gets the infection. Then what happens? So I think we cannot put ourselves at risk. And I'm saying this repeatedly because please look around and see that the number of people who have got infected while treating, while caring. And if you look around, not so many have actually got infected in the COVID area because all precautions have been taken. It's in the other areas where you don't know who has COVID and not, in the emergency, in other areas. So I would, with folded hands, request you, please protect yourself. The cost will have to come out and someone's going to have to pay the cost, and it's going to be a challenge because I know we are a very cost sensitive system where people look at 100 rupees, 200 rupees, 1,000 rupees. But at this point in time, I don't think we can compromise on this at all.
The second thing they're asking you is, this, I've bolded all the questions to 2 questions for you. The second question is, in your institution, I'll read the whole question. I have a 30-bedded nursing home. For me, things as it is are difficult. Maybe difficult at your end for the corporate because you have a lot of money to pay to so many places. But if any healthcare worker of yours gets fever, she's not writing anything else, has fever, do you let them go, or will you let them go or leave? Or what protocol would you follow for them to come back on work?
Thank you. Thank you. This is a very relevant question, and each one of us is going to have to answer this today, tomorrow, next week, next month. I think the ICMR guidelines are what we follow. We have a very clear protocol in terms of who is to be tested if you are a healthcare worker and you are asymptomatic. If you have come in contact with someone who's lab positive, confirmed COVID, and you are asymptomatic, then you need to be tested once between day 5 and 14. And only when you are negative are you supposed to come back to work after day 14. These are what the guidelines are. The guidelines also very clearly define that not every exposure is like an exposure. If you're wearing PPEs and you are actually coming in contact with someone who's COVID, well, that is not really something that will put you at risk and that you have to go through testing. So my suggestion is please look at the ICMR guidelines. Also, please look at NCDC. We do this every day. The NCDC Resource Center has multiple advisories that come on every day. Ministry of Health and Family Welfare, different state departments of health, ICMR, and NCDC. Please look at them. There's a wealth of information which is very useful, very practical. We check it every day. Of course, we have our own red book that we've made for all our hospitals and how we have to manage, but we revise them. We've already on the 5th version because things keep changing all the time. But we check every day what's available on the government websites.
So the crux goes to the fact that we all need to check what's on the government website. Things are evolving and changing every day. Every new thing which we get, we need to follow. And we need to train our staff, have registers for everything. And we really need to follow the process to keep ourselves and others safe. This is something which I...
Sunil, can I add an important point?
Yes, please.
Sunil, we have been practicing for 32 years, whether you are an entrepreneur, an institute. I think so. This is a clear time when, for example, somebody comes for laparoscopic surgery to me, somebody comes for IVF to me. patients who are coming for delivery to me, we are seeing them. Fundamental philosophy of any practicing person is, as Mr. Shibbal told rightly, is you can't dare to compromise. What I'm trying to tell is, if you have to do a test of RT-PCR 4,500 and maybe do IgG, IgM later on, if the patient is not in a situation to afford it, it is the hospital who is going to do, because I am paying 6 of my sister who are at home, 6 of my boy who are at home. So my point is, this is a time when you can't look as how I will survive. So we have to be very clear that if you are taking anything, take full responsibility. And financial burden, whatever it is your little reduction in so-called whatever you were earning prior to COVID time. So at this time, you cannot act stingy at all. And no work goes away everywhere. You know, we have people in line waiting for doing hysterectomies, fibroids, etc. Nobody's going anywhere. But your responsibility is safety for us, safety for our staff, safety for patient. If they cannot spend it, we spend it.
Absolutely. Absolutely.
I'm going to have to go
Okay,
off, Sunil, Ashok Bhai, Jayant, the team. Thank you so much. My apologies.
Thank you, Anupam. I miss
Thank
the old
you.
days.
Thank you,
I
Doctor.
miss the old days when we were together. They were fantastic too.
Thank you so much.
Okay,
Thank
bye-bye.
you, Dr. Sibal. Thank you very much. We really appreciate it.
Really appreciate you. Sir, the best thing to happen is, I just got a message from Sanjeev. The question answer session has increased the number of people. So we have about, it's crazy. We have over 1900 now in the question answer session, which means it really must be going interesting. Dr.
I
Krishnan?
think, Sunil, can we direct some questions for Alpesh, please? Because
Yes.
that is a very big part of, and he's
Correct.
from London.
Yeah,
So
yeah, I
he
will.
provides-
I will. I just have two questions which are specifically for Dr. Krishan Kumar. I don't know why people are asking you this question, but I think it is your attractive personality why it's being asked. And the question is, I'm a 57-year-old lady who runs a nursing home, a gynecological and obstetric practice. I am on methotrexate. Should I open my nursing home or should I keep it closed?
Definitely, a guideline says that if you are on immunocompromised drugs and if you have severe comorbidities, you please stay away from your practice. So if you have somebody else to look after, your family member, give them or ask your friend or pass it on to your authorities that you cannot run your nursing home because of this severe. Methotrexate is definitely not permitted.
Great. A question for Dr. Alpesh, which has just come in. A semen collection needs to be done. You were saying something about a roadside collection, which probably, what is it exactly?
No, so what that means, patients just do the sample at home. You give them the container and everything ahead of time, and they don't enter the clinic. It's to prevent the amount of interactions of the patients with staff. So one of the embryologists or clinic staff wears the full PPE, stands outside of your clinic with a box where there is no direct contact. The man puts the pot of the semen in there, and that's brought up for processing. So that's what I mean by roadside collection, not necessarily.
Let this not go into Indian mentality. Sunil, take care.
You know, the moment you said roadside collection,
we will have trouble. Don't do that.
No, the moment you said roadside collection, people thought there's so many things we do on the roadside, but this we've never done.
Please do not include it. Do not put it in your website.
So probably that must, but it's interesting. It's interesting because the questions are absolutely live and beautiful. Believe me, that's what's the beauty of the whole thing. So I have a question at the moment, which is a very pertinent question, which I would like to ask Dr. Jayant. Dr. Jayant, I like your mic clear because we're not able to hear you.
Am I audible?
No, it's not too good, you know. So just try your best. Okay, the question is there any guideline for closure and reopening of a clinic or a nursing home?
As per recent guidelines, they were discouraging doctors to see general OPD, regular OPD. In few cities, they are allowing.
No,
In few cities, they are allowing. 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 In few cities, they are all in
Yes,
few
please.
cities,
they
they have allowed
I think
short
you are
time.
open on two devices. I think
No,
you
no,
are
no.
on two devices.
You are two devices. You are on another device. So please get the other device closed.
You are having echo.
You're having an
Yeah.
echo because you open on two devices. You open on
I,
your phone as well as on your laptop.
yeah, I can see you are double Jayant Kumar, Jayant Sharma.
Okay.
That's
This
Okay.
question.
Sir, is
Sir,
it
Now,
true?
now this
now,
question.
is it okay now?
Yeah.
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 Yeah. Sir, now they have allowed in few districts, they have allowed short time OPDs.
No, I'm not talking of OPD. They're
Yeah.
asking if
Yes.
what is the guideline to close down the establishment, and in case a COVID has been found, they close it down. What is
No,
the
there,
guideline
there,
to
there is
open it?
no, there is nothing like closing down. Closing down means shutting down a center
Yes.
if COVID patient is found there or positive or tests are positive. Now this is no quarantine is also. I mean, terms have changed. First thing is you cannot close down. You can just sanitize. Sanitize means you can make that center ready for to work again after a day or two. It is not that you can close it for 14 days. One thing. Another thing is if you find a patient, doctor, if you find a positive patient, then if you are quarantining the doctor, then you can quarantine them in the same hospital or home quarantine if they are not in direct contact of their patient.
Dr. Shanta Kumari, I would like to ask you a question. There is a question. I am an obstetrician in the periphery of the rural area of the country. How can it be expected from me to do deliveries in this area in a cost-effective manner where no PPE is available?
This is a very delicate question.
Very tough.
What we
Very
have
tough.
actually seen in the past few days in our state is the number of atypical deaths in our government sector, public hospitals have increased. This is because I think probably outside because of the lockdown and all these PPE issues, the small obstetric units were not functional. So patients
Yes.
were not able to get the care at their place, and then they are moving in the late stages when the symptoms are not very clear, and unfortunate atypical maternal deaths have occurred. But there is no way that anybody can do an obstetric practice without using PPE. Precautions have to be used. Probably we need to evolve nowadays. I think we need to look slowly into reusable PPEs. So that will be the cost effective way forward. Already people are thinking and they're trying to see where they can get the reusable PPEs, which will make the cost effectiveness possible. I think that is the need of the hour. And I'm sure
Correct.
with our innovative minds, we Indians are going, many of them have already started in some of the hospitals.
Yes, sir.
National,
Yes, Dr. Krishna Kumar.
national bodies like IMA and other NGOs should look into this particular
Yes.
problem of the rural areas and see whether they can provide PPE somewhere. Government has to
We
be
have-
sensitized.
We have already sensitized
Yeah,
these government officials, but problem is PPEs are not available. They want to work. People in remote area, they really want to work. Not only obstetrician, other doctors also, and PPEs are not available. Availability is a big problem, big challenge.
I
Today
just
only
want
I
to
was-
insert myself for a second and saying that we are talking a lot about PPE, but remember, not all PPE are the same. So
Yeah.
the standard
yes.
for PPE which are effective against this deadly virus must be tested, and they must be certified by a certifying agency of the government. And I think even in the United States, a lot of substandard PPE are being pushed because there is so much demand, and the governments and companies are going around looking for PPE from all over the world. They are trying to source through the supply chains are just outstretched. So it is important to remember that in the rush of trying to help the patient, you are not harming without knowing that the PPE that you're buying or using are useless against the virus. It just gives you a false sense of security, and actually will do a lot of harm, and later on may actually open your practice to liability for procuring and providing those PPE to your patients as well as to your staff. So this is extremely important to make sure that the PPE should not be compromised, because there are so many studies which are showing that this virus can pass through a large number of filters and barriers. So it is something that people must be told and explained and educated that this is not a simple matter.
There is a very interesting question, and the question is, what registered? I am fed up of maintaining registers. This problem I have just realized I will have to maintain a few more registers. If these registers are not full, will I be penalized by the CMO of my area? So, Dr. Jayant, what registers are needed and what registers are to be maintained?
Sir, if you are seeing fever patients in your OPDs, you have to maintain a fever and flu register. First thing, you have to maintain like nowadays UHID number is being issued to all your patients. So there is a data in your computer. Whatever patient you are seeing today, you have to send a note of it to CMO or I mean registered authorities. So one and then if you are doing some surgery, you are making a register and you are registering them or your computer is doing that. So main is flu and cold register, which is very, very important. Sanitization registered is very, very important. And few other registers like your cleaning, biomedical waste, these registers you have to do, you have to keep. And if something goes wrong, penalizing, as Dr. Ashok said, it is very right. If you are in India, authorities are not against practice, doing operations, this, that. They are more against hiding facts. It has happened in one of the hospital in Meerut and in Agra. They were not showing proper register and not showing proper record. Then there was a problem. Another hospital, same thing happened. A patient COVID was positive. Then they asked for the record. They gave all the record and beforehand they sent. So this hospital was spared and there was only sanitization and quarantine of the staff and all. So you need to maintain all record and you have to show it to authorities. Please understand, this is your practice. You have to save yourself. And if PP is not there, like Madam was saying, in remote areas and all, try to stay away from your work as long as it is possible.
There is a very interesting question which has just come. And Dr. Alpesh, you must be realizing it's a different scene altogether. It's absolutely so different. And Dr. Ashok, the way it is happening, and the question is that the directive now is that from the 4th of May, we have the right to open our OPDs and our OTs, even in red areas, red zones, except for contaminated zones or contained zones. Will this mean that our patients and authorities can force us to open our clinics while at the moment I am not comfortable of going to the OPD? I think this is a beautiful question.
Sunil,
yes,
Sunil,
please.
One is, I was seeing my name is written as Somil Trivedi, which is my son.
Yeah, you have to change it.
Yeah. I don't know how
No, it is, sir. It is because of the login, and yeah, it is from your side, Dr. Trivedi.
Yeah. No, I was in a previous seminar. So no, I was just suddenly seeing that whether I have lost 16 kg, that's why they put me Somil Trivedi. Yeah, Sunil, you had an interesting question.
Yes, please.
Yes.
Yeah, no, what you're trying, see, what we are discussing what is happening in India and what we should do in India.
Sir, the question is very simple.
No, simple.
Yes, please.
See, we get directives. The directives is not binding that you go and take risk and you do it. If you don't want to, you remain and sit at home. The directive clearly means that if you can take good precaution and you can serve the community, please go ahead and serve the community, because government hospital beds are not available. COVID private beds are not available. So basically point is, if clinicians and obstetricians and physicians and all are practicing, they will take care. So we have to take due precautions. 2nd May is today, 2nd August will come. Eventually we will have to go and practice. So it's up to a person whether they want to practice. And if you ask me, I honestly want to practice, taking all the precautions. So I don't have any inhibition, because there will be some amount of risk always.
I think what this person what this person wants to understand is, I don't want to practice. Will the patients and the authorities force me to practice?
Yes.
This is what.
See, government has never told you to stop practice. They just told avoid elective surgeries. You are supposed to take care of your non-COVID patients. The other patients, they want doctors and nursing homes to be open. So the authorities can take action if you think you're not going to just for the fear.
Dr. Jayant, will you answer this question, please?
For the fear you're going. Yeah.
Yes. Sir, we are under Essential Services Act, being doctor.
Your voice is not coming. You have muted it.
Morbidity or something, related to your health, as one doctor was on methotrexate, they can show their papers and can abstain from their work. Otherwise, government authorities, it is very much clear that you have to open your hospital, even if it is a red zone, then you have to open and you have to run your OPDs, look after your patients in needed surgeries. If you can defer them, fine. You cannot deny. Dr. Krishna Kumar is very right. We have to open, and we cannot escape from our work.
Alpesh.
Hi. Sorry, I just wanted to say something in the context of UK. I don't think that the choice is essentially either the clinics or the regulator or the patient. I think firstly, we need to understand that we have to be ready for it. And I think the risk assessment is very important here. And I think for our viewers who may want to see what risk assessment templates that we have been what our regulator has given us, and we will be getting that on Monday. It's a self-assessment, risk assessment, self-assessment questionnaire. And that tells you yourself as a clinic owner whether you're ready to open or not. So I don't think the choice should be either mine or the employees or the patient. It's whether the establishment is ready through a centralized assessment of your practice, your premises, your staff, etc.
Is it a self-assessment or is it an assessment done by the authorities or the regulator?
It's a self-assessment. There is 46 questions that are very, very specific in asking you whether several aspects of your practice, your laboratory, your clinic, your treatment room, your patient information leaflets are ready to start seeing patients. And as I said, I'm very happy to share that as we get it on Monday, just for the wider fraternity to assess themselves.
If you could just share it on the group which we had on WhatsApp. We're going to link it and make a whole file of all the papers and send it to all the people who logged in.
So it is definitely more specific to fertility and not necessarily
to general,
but I'm sure there's a lot of transferable elements.
Sunil, can I make a comment? Sunil?
Yes, please.
Now, see, you have to realize if you have a staff of 30, 35, my both receptionists, one is staying at Borivali, Kandivali, one is staying at Dombivali. They cannot come. Amongst the nursing, 9 or 10 we have. So it actually depends whether you have adequate staff to handle the workload you are taking. Point number one, you have in OT a good qualified, adequate person. Fortunately for me, my wife is embryologist, my daughter-in-law is in ART. So as far as ART is concerned, those issues are not there. We are not facing that because a OT tech, which was in 35 years in Jaslok, is coming on daily basis. One sister has voluntarily agreed to stay 24 hours. So things also depends on the understaff, how you motivate them, how you tell them, because we cannot force anybody to come, though with the batch they can commit, but we obviously want that we are ready to serve and you have those staff which is committed, so you keep them well, and all the staff which is not coming, you're going to keep paying. So it depends on multiple factors, which may be a situation what you're telling, somebody doesn't want to
Correct.
essentially take the risk.
Correct. Now, the problem which I'm facing now is I'm getting questions in both my phones. And there's so many questions. I'm just wondering what to do. Now, one question is interesting, so I'll ask you. And then I think we should wind up only because of the reason, and we should have the next time only a question answer session. That's all.
And
We
Correct.
should have.
you continue answering on your phone the questions
Okay.
which has
No,
come.
but one question has come. One question has come for Dr. Alpesh, and the question is: have you taken hydroxychloroquine?
No,
No, I
No.
haven't.
no.
And the second question with it is, as a healthcare professional, do I give it to my staff now since it is opening?
So
Now
There
this
is
is a
no,
question. No, this is a
there is,
question.
Let me try
Yes.
to put
Yes, please.
our spin from the United States. Mr. Trump, our president, was pushing for it, and you heard of a study, I think, which was published, a smaller study, which seemed to indicate that patients who were on hydroquinone actually, when they were infected with COVID, and they had a very poor outcome. Almost half of them didn't make it compared to those who were not. So I think it was about 400 patients study that came out, and ever since, and Mr. Trump is known to make all kind of wild recommendations and suggestions, and he doesn't believe so much in science and medicine. So I think people have to be very cautious because the benefit of hydroquinone in any of the study have not been proven. It is anecdotal, and I believe that people had in India believed that because the incidence of COVID in the beginning stages was very, very small in India, that there was a theory on the WhatsApp University that Indians are probably more prone, more resistant to getting this deadly virus because they had malaria and all these kinds of diseases before. So their immune system can fight it off, and they just have to kind of make it more stronger by taking hydroquinone once a week. But I believe that really is, again, like many other kind of things that we see are not based on solid science. So yes, if you want to take it, you are more than welcome to take it, but there is really no solid science in support. And there are, as Dr. Sibal told, all that science is coming on so rapidly on PubMed. Not all the papers should be believed, because a lot of people are doing the studies, they are checking, and they're publishing a small amounts of studies with different types of data. It's just like 4 blind men touching an elephant, or like a virus, and they are saying that it looks like a fan, or it looks like something like a tail. So everyone is trying to make sense of looking at the data in their own clinical centers. We see hundreds of papers coming from China, and they are being published. But I think the data is really something that even in publication should be taken with a grain of salt, because it is not really telling us the entire story, and the story is developing. So we'll have to wait for another 6 months or a year before we know whether those stories really come out to be the truth. So just being published in a peer-reviewed journal does not make that paper or that data to be completely trustworthy. And certainly anything which is anecdotal, as physicians, as scientists, we know cannot be trusted.
Yeah, Dr. Ashok Agarwal and Sunil, from 4 to 6:30, we were in a major session on COVID with an internal medicine person who has dealt with pandemic, written a book on COVID and all the details. He had made a very clear statement that there are no documented evidence, or there is definitely an evidence that HCQ does nothing to COVID. So he was very clear that there were antivirals told, the plasma therapy told, and that was in his book, that 250-page book. I have read it myself. So there are many things which are clear, but as you're rightly pointing out, a lot of people take a cue because we had one of our past president of Foxy telling, no, we are taking on regular basis once a week. And when I discussed with this Dr. Swapnil, who has written a book, he told HCQ has definitely no proven role in COVID.
It is claimed that that just gives a psychological boost to their immunity. That is it.
No
That is the reason they say they take.
all
Now,
sense of security.
so we are already about 3 hours into the program, and we still have people with us and questions with us, but I think it's time that we could wind up and probably answer the questions later on. It's amazing. The vote of thanks, of course, has to be given by Dr. Ashok Agarwal, because he is the man who puts everything into place. But there is only one thing which I personally feel at the end of it is that this is beautiful, beautiful. मतलब शेर फिर सुनाने का मन कर रहा है, मैं कुछ कर नहीं सकता। और ये इतना खूबसूरत है कि किसी के गुजर जाने के बाद शहर बंद होते बहुत बार देखा है। किसी के गुजर जाने के बाद शहर बंद होते बहुत बार देखा है, लेकिन कोई गुजरे नहीं, इसलिए शहरों को बंद होते पहली बार देखा।
Wow, wow,
You have repeated.
This is repeat.
You have repeated.
It's a repeat. Okay, फिर मैं
Yes, but it's required. It's a worth repeat.
But the truth is that today there is so many new things into which your mind, my mind, everybody's mind is going. Even the mind of somebody who's selling fruit is going, that how can I survive? And the spirit of the human being at this moment of trying to create the best out of this time of the pandemic is the story for all of us. And I personally would really appreciate all the speakers, Dr. Alpesh, Dr. Jayant, Dr. Prakash Trivedi, Dr. Krishna Kumar, Dr. Shanta Kumari, Dr. Ashok Agarwal, of course, is my goodness. And apart from that, I would also like to thank Dr. Sibbal, who's not here. But I'd also, more importantly, thank this beautiful audience which we have, which has been here for so long. And I really appreciate your patience, and that is only because you want to learn something which you really want to know. And there is so much we would like to learn from your questions have given so much of insight to us. Thank you very much.
Thank you.
Bye.
And good night and good morning, everybody.
Good night.
We can, the speakers can stay for a minute for debrief, and I think we can stop the live. Sanjeev?